When thinking about redesigning the patient journey, an area gaining traction is enhanced recovery after surgery, which is what I'll be speaking to today. Firstly, enhanced recovery after surgery goes by many names. It is commonly referred to as ERAS, and other common terms also include fast track surgery, as well as short stay surgery. Before I go into what ERAS is, a little bit about its history. ERAS was first described in a seminal study by Kellett and colleagues for patients undergoing colonic resections in 1995. Since this study, ERAS has gained traction worldwide, and in fact, in 2001, a collaborative study group was started that grew into a multinational group, known as the ERAS Society. Such is the popularity of ERAS that research within this space has been continuously increasing, and similar trends are also witnessed for ERAS surgery in arthroplasty. In fact, the popularity of ERAS has grown to such an extent that there are multiple centers of excellence that have been established across Europe and the Americas. So then what is ERAS? All ERAS programs have one thing in common. That is, they're a multimodal care pathway that aims to reduce the surgical stress response and accelerate recovery of function. The emphasis being accelerating recovery. Before I talk about what ERAS involves, we need to first put together a team. I've listed here just some of the personnel required for the success of ERAS, and we can see that they encompass everyone from hospital management to the theatre staff, emphasizing just how crucial each person involved with arthroplasty is to an ERAS program. And now that we have an idea about who we need, let's have a look at what it involves. ERAS programs vary from health service to health service. As a way of aggregating different protocols, the ERAS Society, which I've mentioned earlier, recently released a statement describing the key interventions within ERAS surgery for arthroplasty. These interventions can be divided into three large categories that occur around the time of surgery. Firstly, starting with those that occur in the postoperative phase, those that occur intraoperatively, and lastly, those occurring postoperatively. As is the case with any surgery, a patient's surgical journey starts in the preoperative phase. In the preoperative phase, ERAS consists of two major components, the first of these being education. It is vital that patients receive the right information and support to facilitate early recovery. While structured education programs may improve pain or may not improve pain or facilitate functional recovery, they do allow for realistic goals to be established and lower preoperative anxiety. It is imperative to have patients buy into the idea of ERAS, as the patient must be on board to participate. The second key component in the preoperative phase is patient optimization. Like any other surgery or traditional arthroplasty pathways for that matter, comorbidities should be controlled with an emphasis on smoking cessation and anemia correction. Moving into the intraoperative phase, we can see more components. The first being the use of standardized anesthetic protocols. Most published protocols for ERAS arthroplasty consist of spinal anesthesia. This choice being driven by a decrease in 30-day mortality rates, a reduction in hospital length of stay, and a reduction in complications witnessed with spinal compared with general anesthesia. The second part of intraoperative management involves limiting the barriers to mobilization for the patient. The first of these being pain. In the case of total knee arthroplasty, this takes the form of regional anesthetic blocks, as well as local infiltration of analgesia, which involves a cocktail of an anesthetic drug, non-steroidal anti-inflammatory, and adrenaline being injected in and around the incision. Another is blood loss. Traditionally, arthroplasty has been associated with pronounced blood loss, which can significantly impact on a patient's ability to participate in physiotherapy, and is associated with the need for postoperative blood transfusion. Tranexamic acid functions to decrease the blood loss at the operative stage and therefore limit the need for postoperative blood transfusion. And finally, intraoperative ERAS management also considers the practicality of mobilization with the avoidance of interventions that can impair patients' ability to mobilize. ERAS pathways avoid the use of tourniquets for knee arthroplasty, as studies have shown they may impair early functional recovery. They avoid indwelling urinary catheters, with studies finding no benefit to the use of catheters compared to their intermittent use or no use at all. And lastly, surgical trains are also avoided with no evidence to support any positive effect. And lastly, in the postoperative phase, the aim of the game is mobilization. And rightly, the first intervention in ERAS involves early mobilization, with patients being mobilized on the day of surgery, aiding to counteract the recognized effects of prolonged bed rest. The other interventions are concerned with eliminating factors that may limit a patient's ability to mobilize. The first of these being multimodal analgesia. By combining different classes of analgesics, we are able to utilize different modes of action and therefore yield an additive pain relief benefit. Doing so enables ERAS pathways to decrease their reliance on strong opioid analgesics and therefore avoid the well-known side effects of opioids. Paracetamols and non-steroidal anti-inflammatories are the mainstays here. Lastly, ERAS programs also consider postoperative nausea and vomiting prophylaxis. Nausea and vomiting can be a very distressing symptom to patients and can severely limit their ability to mobilize after surgery. We've already discussed some strategies to reduce postoperative nausea and vomiting, namely the use of spinal anesthesia and the avoidance of opioids. But those patients at risk of developing postoperative nausea and vomiting should also be supplemented with additional prophylactic therapy. Lastly, each of these components, both individually and collectively, function to promote early functional recovery of patients. We've talked a little bit about some of the individual components of the pathway and how they function, but how does ERAS actually work? We know that the key method that ERAS is proposed to work through is by reducing the surgical stress. So then if we were to plot a patient's functional status or ability over time, you'll get something that looks like this. And in a traditional pathway, a patient would enter arthroplasty undergoing preoperative screening and then head to the operating theatre for their procedure. Here, the primary pathophysiological change occurs at the time of surgery, hence contributing to a significant reduction in the patient's function. After surgery, the patient's able to participate in physiotherapy and function is gradually restored. Compare this to the functional status of patients undergoing ERAS surgery. Here, prior to entering the operating theatre, patients are optimized. Once they do enter the operating room, though, there's some techniques that we talked about before, such as spinal anesthesia and tranexamic acid are utilized, which function to reduce the pathophysiological burden of surgery. And as such, patients are able to maintain a greater functional reserve compared to conventional pathways. After surgery, interventions such as multimodal analgesia, local infiltrative analgesia, as well as limiting the barriers to mobilization, are utilized to promote early functional recovery. And therefore, the time required to patients to regain their functional status is shortened. We've had a look at what constitutes ERAS pathways and how they're thought to function, but an important consideration is also its outcomes. As mentioned previously, one of the barriers to recovery is pain. A number of studies have been conducting involving ERAS programs, have found that ERAS actually provides an additional benefit to pain management compared to a traditional arthroplasty pathway. This is exemplified by a study conducted by Sid, which showed that ERAS pathways significantly reduced postoperative pain, both at 24 hours after surgery, as well as at 48 hours after surgery. One of the other key outcomes that ERAS is measured by is through length of stay, as length of stay largely captures a patient's return to function after surgery. A recent systematic review summarizing a number of different ERAS programs in arthroplasty from a number of different centers worldwide found ERAS reduced length of stay by a factor of more than a day. Lastly, with any such program, we also should consider its safety. Safety can be measured in several different methods, and here I'll concentrate on readmissions and complications. Firstly, looking at 30-day readmissions, as shown in the meta-analysis at the top over here. No difference in readmission was found between ERAS pathways and traditional arthroplasty programs. Looking at complications, shown at the bottom over here, ERAS pathways are actually found to be associated with a reduced risk of complications compared to traditional arthroplasty programs. And as such, some may argue that ERAS surgery actually represents a safer surgical pathway. So in summary, putting it all together, ERAS is a highly protocolized pathway that encompasses the preoperative, intraoperative, and postoperative phases of admission. Its primary function is to facilitate the recovery of patients' function, which is achieved by aggressive pain control, removal of barriers to mobilization, as well as early mobilization. And lastly, the effects of ERAS are witnessed through a safe reduction in hospital length of stay. Thank you.